without further ado, I'd like to introduce Dr. Gabor Maté, and I know you're going to have a wonderful evening listening to him, and that'll be great food for thought for you, all of you who are concerned or interested in addictions. So let's give him a very warm welcome.
Thank you, Kaylin and Rebecca. Can you hear me at the back okay? Yeah? Great. If there's any problem, just let us know. So thank you for honoring me by showing up tonight, and certainly it's an honor to have my book have been chosen, although it's an honor, but it's a deserved one. Because I happen to think it's the only book that makes any sense out of addictions out there. So I'm not necessarily modest about it, and it's not, you know, my brilliant insights, although they're there too, but I'm talking about the evidence that has accumulated over the years. I'm talking about the experience of thousands of people. I'm talking about the research that has been published on brain development, on addictions, on physiology, on psychology, on child development, on trauma. I'm talking about all that, and I'm talking about all that is completely missing from the curricula of most medical schools, most schools of psychology, schools of education, nursing programs, public health programs, and so on. And that's not a blanket true statement, but largely it is true. So what I'll be presenting you with is a perspective that it's rather different from the mainstream, but which is evidence-based. And if there's one phrase I could eliminate from the medical lexicon, it would be this evidence-based practice. Because I only wish that we actually based our practice on the evidence. Then we would know that whenever we see cancer, or when we see arthritis, and certainly when we see mental health issues or addictions, we're not looking at random, isolated events in an individual. We're looking at something that has a history that is rooted not just in an individual, but in the history of that individual's family over the generations and in a larger society. Now, when we look at addictions, we're somewhat flabbergasted and we're shocked, really, at what people do to themselves. So I'll read you a little bit from the second chapter of In the Realm of Hungry Ghosts, and it's entitled The Lethal Hold of Drugs, this chapter. And just a conversation I had with a client of mine. Now, I was a family practitioner for 20 years, 7 years I did palliative care work, and then for 12 years I worked in addiction medicine in Vancouver's downtown east side. So this is a scene from my clinic 9 years ago now. In March 2005, I had a discussion with Alan in his 40s and with HIV. Alan has been to Vancouver Hospital with sharp chest pains a few days earlier. He was told he had probably suffered a flare-up of endocarditis, an infection of the heart valves. Declining to be admitted to hospital, Alan presented himself for a second opinion at the emergency ward of St. Paul's Hospital, where he was assured that there was nothing wrong. Now he was in my office for a third assessment. On examination, I can see that he isn't acutely ill, but is nevertheless in terrible shape. "What should I do, Doc?" he asks, raising his shoulders and spreading his arms out in helpless consternation. "Okay," I say, reviewing his chart. "Your father died of heart disease. Your brother died of heart disease. You're a heavy smoker. You have a history of endocarditis from IV drug use. I'm treating you for cardiac failure, and even now your legs are swollen because your heart isn't pumping efficiently. Your HIV is controlled by strong medications, and with your hepatitis C, your liver is just hanging in there. But you still keep using and injecting, and you're asking me what you should do. What's wrong with this picture?" "I was hoping you'd say that," Alan replies. "You need to tell me that I'm a f***ing retard. It's the only way I learn." "Okay, Ayublaj, you're a f***ing retard." "Thanks, Doc. The trouble is you're not a f***ing retard. You're addicted. And how are we to understand that?" Alan died 4 months later, cold blue on midnight, on the floor of his room in a nearby hotel. He was injecting, rumor had it, from a bad lot of methadone heisted in a break-in at a local pharmacy, and subsequently adulterated with crystal meth or who knows what. According to the coroner's office, that little enterprise in independent drug marketing caused the deaths of at least 8 people. "I'm not afraid of dying," a client told me. "Sometimes I'm more afraid of living." And that's the real issue. That's the real issue. Keith Richards, the Rolling Stone guitarist, who as you know, had a significant heroin habit. In his autobiography, Life, he says, well, what was all that partying, heroin all about? He says, I suppose, he says, it was about the need for oblivion, the contortions we go through just not to be ourselves for a few hours. So the real issue is, why are so people afraid to be themselves? And why do they find life so challenging that they have to escape their consciousness by obtunding it with substances or certain behaviors? Now, that's not a question that either the society at large or the treatment industry really cares to ask. We have our assumptions about addiction. And the most common and prevalent addiction, and that's the one that informs the legal approach to drug use, is that it's a choice that people are making. It's just a bad choice. So if people are making a bad choice, then what do? Then you deter them from it. Basically, it's the punitive parent approach. The kid misbehaves, you punish him. You're not interested in what the kid is actually portraying through that behavior. You just want to stop the behavior. So it's one of heavy, and as you know in this country, extremely heavy legal sanctions. And the result of that approach is, you're probably aware, that the American population makes up 5% of the world's population as a whole, but 25% of the world's jail population. And that means that every fourth person in the world in jail is a citizen of the land of the free. And that's the result of this idea that this is all about choices that people are making. The second approach, which is what you might call the medical approach, is that addiction is actually a disease of the brain. And it impairs brain functioning and decision making and so on. Now, there's a lot of truth in that, of course. But when you ask what causes a brain disease, and if you go to the definition of addiction given by the American Society of Addiction Medicine, well, addiction is a brain disease and caused about 50% by genetic predisposition. Now, what the choice model and the addiction and the disease model have in common, though, as different as they are, and they almost seem antithetical, because if it's a choice, then why are you punishing it? If it's a choice, then why talk about a brain disease? And if it's a brain disease, then why punish people? So the two seem contradictory, but they have one thing in common. And what they have in common is that they both take society off the hook. If it's genes that we inherited, or bad choices that we made as individuals, then we don't have to look at what actually happens to people in our culture. We don't have to look at what happened to them in childhood. We don't have to look at social policies that favor some groups over others. We don't have to look at the history of certain minority groups in this country or in my country, Canada. It's just choice or genes. So, different as they are, both of these perspectives allow us to avert our eyes from some very disturbing social questions and some very painful individual questions. There's only one problem with that approach. Both those approaches, they happen not to be true. Now, if you look at the genetic perspective, let me give you a clear example, a tragic example actually, that's shared by your country and mine, which is the experience of the Aboriginal people here. Now, there were substances that changed consciousness known and used by the natives prior to the colonization from Europe. There was peyote, as you know, in some areas of North America. In southern United States and in Mexico, there were alcoholic spirits. There was tobacco known to many of the natives, psychedelic mushrooms, and so on. And as I said, not only were these substances known, but they were used. They were used regularly, without addiction. How were they used? Ceremonially. Now, the ceremonial use of a substance is the direct opposite of the addictive use. Because the addictive use is all about obtunding consciousness. It's about going blotto. It's about escaping. It's the contortions we go through just not to be ourselves for a few hours, to quote again Keith Richards. Ceremonial use is to reach a higher level of consciousness. It's to be more connected. It's to be more aware. It's a ritual thing that you engage in with community, not in the isolation of your room and in shame. So it's the very direct opposite. Now, if these people were genetically programmed to be addicted, why was there no addiction prior to colonization? And not only that, even after colonization, and you get these very strong alcoholic substances introduced by Europeans, even then that didn't lead automatically to addiction. Like the Innu, the so-called Eskimos of northern Canada, they drank the whiskey and they loved it and they go drunk and so on, but they were not alcoholics. They were able to live their lives, go hunting, fishing, maintain their communities, bring up children in a healthy way, until something happened. And that thing that happened is when they lost their right to live their lives the way they knew how to do it. So addiction could not have been genetic, because if it was, they should have been addicted a long time ago. So that's the first problem with those perspectives, is that they're not true. Secondly, one way or the other, they make an assumption. And along the many mythologies that bedevil the addiction field is this idea that drugs are addictive. Now, we know they're not. I mean, let me ask you this question. Is alcohol addictive? Well, if I asked amongst you here how many have ever had an alcoholic beverage, most of you, I dare say, would put your hand up. But if then I asked how many of you had an addictive relationship to alcohol, it'd be a much smaller number. If the alcohol was addictive in itself, you should all be addicted. You should all be alcoholics. Most people who try most drugs, whether it's heroin, crystal meth, cocaine, cigarettes, caffeine, alcohol, never become addicted. Therefore, you cannot explain the addiction by the power of the drug itself. Nor can you therefore stop addiction by trying to stop the availability of substances. The real issue is, why are some people driven to addictive behaviors? What is it that impels them in that direction? And once they've had that experience, why can't I give it up? Now for that, you have to look at individual lives and social issues in the broader context. You're not going to resolve that one by doing brain scans on people and showing that they've impaired brain circuits, which they do. But how did they get there? That's the question. And what I'm suggesting to you, that if the choice model and the disease model are inadequate to the explanation of addiction, then what's really going on? What's really going on is that the central fact about human existence is utterly ignored in mainstream medical theory, which is that the brain is inseparable from the body and the individual is inseparable from the environment. Now that little baby there, every second that I speak, he or she has millions of new connections being formed in the brain. And all that is happening in relationship to the environment. And I'll explain something about that later on. So that you can't separate brain physiology from the environment. And this is true for all of our lives. So you can't separate the mind from the body, as we do in Western medicine, and you can't separate the individual from the environment. And so what we really need, what we require, is what's been called a biopsychosocial perspective. And biopsychosocial means that the biology of people is shaped and influenced by their psychological and social relationships. And that's really easy to show. So we know, for example, that kids whose parents are stressed are more likely to have asthma. So in polluted areas where there's more asthma, it's the kids whose parents are most stressed who are most likely to have the asthma. And I'm not going to go into the physiology of it, except to say that we actually treat asthma with stress hormones, adrenaline and cortisol. But we never ask ourselves, gee, what's going on? Does stress have something to do with it, maybe? Well, what's really going on is that the emotional stresses on the parent are affecting and having an impact on the physiology of the child, including their lung physiology and their immune system. And this goes on all of our lives. And of course, the more sensitive we are, the more we're affected by the environment. And that sensitivity to environmental influence may be genetically influenced. But that doesn't mean that you're going to inherit a certain disease. It just means that you'll be more prone to be affected by the environment. It's still the environment that shows up and does this or that or the other. Now, in my 50s, when I was 55 or so, and I was the medical coordinator of the palliative care unit at the Vancouver Hospital, I was diagnosed with attention deficit hyperactivity disorder. Well, self-diagnosed actually, after somebody on the unit, the social worker, invited me to have coffee with her, and when she told me about her diagnosis, I understood why she invited me to have coffee. And I just recognized myself, and then eventually I was diagnosed by a psychiatrist, and I was given stimulant medication called Ritalin, but that made me depressed, so I took Dexedrine, and I took that for a while. What these stimulant medications do is they elevate the level of a chemical in the brain called dopamine. Now, dopamine is the central brain transmitter, neurotransmitter. I'll be telling you about it in a little while. But what else elevates dopamine levels? Well, all the stimulants do. What are the stimulants? Well, Dexedrine, Ritalin, cocaine, crystal meth, caffeine, and nicotine. Guess what? A lot of the people who get hooked on these substances are actually self-medicating ADHD. So, on one level, in the medical sense, addictions are always about self-medication. Always about self-medication. Now, cocaine not only elevates dopamine levels, it also, like Prozac, blocks the uptake of serotonin. And serotonin is an important brain chemical implicated in mood regulation. People self-medicate depression with cocaine. People self-medicate ADHD with alcohol and marijuana, which soothes the hyperactive brain. People self-medicate anxiety with marijuana or alcohol. People self-medicate social phobias with cocaine and alcohol or crystal meth. People self-medicate PTSD, post-traumatic stress disorder, with opiates. After the foreign adventures that your country seems addicted to, well supported by my country, by the way, a lot of the veterans come back with PTSD hooked on opiates. It's a self-medication. So on one level, addiction is a self-medication. On a narrow medical level. But we have to go beyond that narrow medical model. But we have to recognize what's going on here. In other words, and actually, when I go around speaking about this issue, and I ask people, I won't do it now, but I did this afternoon. I asked people, well, how many of you have an addictive relationship to a substance or to a behavior? And a number of people put their hand up. And the next question is, and what did it do for you? What does it do for you? Well, it gave me peace of mind. It gave me a sense of control. It connected me to other people. It soothed my pain. It made me relax. Well, what's wrong with any of that? Who does not want to be relaxed, connected to other people, have a sense of mastery, and have less distress, have less pain? In other words, you've got to get this. The drug user, and particularly addicted drug user, just wants to be a normal human being. That's all they want. They want what life should give them, but for some reason has not. They want something we all want. Now, if we look at the drugs and their relationship to brain physiology a bit more closely, what do we find? Well, let's look at the opiates. Now, the opiates derive from the opium plant that goes in Afghanistan. They're the most powerful pain relievers that we have. So in palliative care work, in looking after the terminally ill, I could be really grateful for the opiate medications, because without that, a lot of people would suffer agony in their last weeks or months of life. But the opiates don't only soothe physical pain, they also soothe emotional pain. In fact, on brain scans, when you wound people emotionally, the same part of the brain lights up as if you wounded them physically. And that part of the brain has a lot of receptors for opiate chemicals. So opiates are pain relievers, physical and emotional pain. As a matter of fact, if you look at the substance of abuse, they all pretty much have a pain-relieving quality. Alcohol, as you know, is an analgesic. They used to be used before surgery for people, before the days of anesthetic. Cocaine is a local anesthetic. It numbs nerve endings. It's still used that way in certain kinds of nose surgery. It also shrinks blood vessels so there's less bleeding. marijuana, as you know, has pain-relieving qualities. So the real question in addiction is, and if you get nothing from this lecture except this one line, just please remember this one. The real question is not why the addiction, but why the pain. And if you understand why the pain, you can't look at genes. You can't look at choices. You have to look at people's lives, and as I said earlier, their histories. Then the second question that arises is, well, why did the opiates even work in the human brain? Well, how come this product derived from a plant in Afghanistan has such a powerful impact on human neurophysiology? Well, the answer, of course, is that we have receptors for the opiates, receptors being molecules on our cells that can receive a messenger substance. And if the messenger substance fits into the receptor, then the two together will activate the cell to do something. In fact, the messenger receptor complex tells the DNA of the cell what to do. In other words, it's the environment that turns the genes on and off. And there's a whole new science called epigenetics that looks at how environmental influences actually trigger or turn off genetic activity and therefore influence lifelong patterns of behavior and physical responses. Epigenetics. So we have receptors for the opiates. But now why do we have receptors for something derived from a plant in Afghanistan? Well, of course, the answer is we do not. What we have receptors for are our own endogenous morphine-like substances, which, to put it in abbreviated form, are called endorphins. So we have an endorphin system, we have an internal opiate system. But why do we have that? Well, first of all, for pain relief. We need to have pain relief. So when you give people an inert medication for pain and 25% actually experience genuine pain relief, it's because the belief that they're getting help released endorphins in their brains. It's a physiological effect. So we have our own endorphins to relieve pain, which we have to have. That's their first function. Their second major function, equally important, is the sense of pleasure and reward, elation, joy. Now imagine your life without that. Human life is difficult enough, so that without that sweetening of joy and elation, we would be very miserable creatures. And their third function is actually the most important one. And the person who actually discovered the endorphin system, Candace Pert, called them molecules of love, because they make possible the loving interaction between two people, and especially between infant and parent. So if you took infant mice, this study was done by a great researcher here in the state of Washington, who at least works here now, Dr. Yak Panksepp. And Panksepp showed that if you take infant mice in a laboratory and you genetically knock out their endorphin receptors, these little mice will not cry for their mothers on separation. Now what would that mean in the wild? It would mean their death. So the opiates actually make life possible, because the human infant is the most immature, the most helpless, the least developed of any creature in the universe. And therefore, without that attachment relationship, there's simply no life. And so endorphins facilitate that attachment relationship. And that was exemplified by many conversations I had with drug addicts, but one of them, a sex trade worker who I quote in the book, said that she was 27, and I asked her this question, what does heroin do for you? She said, the first time I did heroin, it felt like a warm, soft hug. And this other fellow, 6 foot something, tattoos, muscles, scars, the whole thing in detox. And I said to him, well, what does heroin do for you? She said, I don't know how to tell you, he says, but it's sort of like you're 3 years old, and you're sick and you're shivering with fever, and your mother puts you on her lap, wraps you in a warm blanket, and gives you chicken soup. That's what heroin feels like. Well, these people are talking about love. So now, Picture a human being who comes to the conclusion, for whatever reason, that without this substance, they're not going to have pain relief, escape from their misery, they're not going to have a sense of reward and joy, and they will not experience loving connection. Well, what do you do to take it away from them? You're going to put a sign on the wall like Betty Ford? Just say no. Just say no to love, pain relief, and joy. That's all you got to do. You know? Now, that's the opiates. Then I mentioned the stimulants, which elevate dopamine levels. Now, dopamine, you take a little mouse, this has been done in the laboratory. You put food in his mouth. He eats it, he chews it, he swallows it. But if you place the food a few inches away from his body, he will not budge to eat it, will in fact starve to death, rather than move to eat the food, because genetically they knocked out his dopamine receptors. And dopamine is the incentive motivation chemical. Without it, we're listless, inert, passive, inactive. Sort of like the average football fan. Sorry, I know you won the Super Bowl. You know. About which I may have something to say in a little while. So dopamine flows when you're seeking food, when you're seeking a sexual partner, when you're exploring a novel object or a novel environment, all of which are essential activities for human life. So that's another chemical without which life is not possible. And that's what the stimulant addicts are giving themselves when they do crystal meth or cocaine or nicotine or caffeine for that matter. There are other brain circuits implicated in addiction. One of them has to do with the regulation of stress. Now, stress is necessary. Stress, it's not a bad word, stress. Stress just means a response in the body to a threat. And how we respond, to make a long story short, is after certain brain messages, we end up releasing stress chemicals from our adrenal glands on top of our kidneys.